Thank you, Tracy, for that somewhat idiosyncratic introduction, which I appreciated. Thinking about what to speak about today, I thought I would cover four main areas of concern. The substantial structural barriers to hepatitis C treatment access for people who inject drugs. The nature of a human rights perspective on hepatitis C prevention for people who inject drugs. The ways in which the harm reduction agenda has been tied to HIV in a way that has been detrimental to hepatitis C prevention and resulted in the current extremely high rates of hepatitis that we still have in the injecting community, even in countries in which the HIV epidemic has been brought under control. And finally, I would like, if I have time, to make a few comments on why so little attention has been paid and why such a low level of investment has been made in addressing hepatitis C amongst people who inject drugs primarily. And I want to start off with two quotations from two different epidemics at two very different points in time. The first comes from Paul Farmer's book, Infections and Inequalities, The Modern Plagues, published in 1999, and is speaking to the early days of the HIV epidemic in New York. Paul Farmer writes this: anecdotal evidence exists that physicians in New York City are acting on their assessment of the likelihood that patients will adhere to therapy. And this is the quote: "It is definitely happening," commented the director of planning of one AIDS service agency in Lower Manhattan. "There is frustration on the part of social workers because they know that some doctors won't prescribe to people who are drug users. The justification for withholding treatment is to protect the public. The doctors maintain that poor compliance with the drug-taking regimen can not only spell disaster for an individual patient, but also create a potential public health risk through the spread of a virus resistant to so many drugs." And the second quotation comes from an essay that, for the sake of full disclosure, I must admit was contained in an essay of which I was a co-author along with my colleague Tracy. "Prescribing sofosbuvir to someone using heroin," the director of the Illinois program told the Wall Street Journal, "would be a total waste." And that's from 2014. So two different epidemics, two very different points in time, one common underlying message. Prescribing medicines to people who inject drugs is a waste of time for various reasons that I will begin to explore. So there is clearly a great deal at stake in this intense focus and this increasingly heard discourse on patient non-compliance, what's called patient non-compliance. And there is a growing discourse arguing that entire classes of HIV-infected or hepatitis C-infected people lack the personal discipline to abstain from health-threatening activities. And in this discourse, the fact of infection is turned into nothing more than a character flaw. In the crude calculus of modern public health, self-protection, and I'll explain what I mean by that, seems to have become the sole justification for effective measures to contain the plagues of the poor and the marginalized, and I'm speaking particularly of people who inject drugs. Now, it's clearly demonstrated that people who inject drugs achieve adherence to and outcomes from hepatitis C treatment comparable to any other patient. Nonetheless, my community is frequently excluded from treatment, either by blanket regulation or by practice. The approval of the new class of DAAs, of direct-acting antivirals, for hepatitis C treatment that are both more effective, simpler, and safer, should offer greater treatment options for people who inject drugs, but exorbitant drug prices in developed countries, $84,000 for sofosbuvir in the US, have led to treatment rationing and exclusion, the de facto exclusion of people who inject drugs at state and national levels. In middle-income countries, where hepatitis C is highly prevalent amongst people who inject drugs, treatment is largely unavailable, except in the private system, and unaffordable for most people who inject drugs. The structural drivers for lack of treatment access for people who inject drugs include, and are not limited to, experiences of stigma in healthcare settings, drug use status being used as a criterion for treatment exclusion, registration by name as a drug user prior to treatment initiation, and frequent incarceration or detention in prisons and so-called rehabilitation centers or compulsory drug detention centers where treatment is completely unavailable. And underlying all of this, of course, repressive drug control policy and blanket criminalization. High medicine prices further force exclusion of people who inject drugs from hepatitis C treatment, with cost containment being masked as a concern about treatment adherence. But I think it's worth bearing in mind, whilst we abhor the high prices, the exorbitantly high prices being charged for the new class of hepatitis C medicines, that even now, when antiretroviral treatment has been brought within the range of affordability, only 4% of people who inject drugs who are living with HIV are currently in receipt of treatment. So clearly, price is not the only barrier. I would like to suggest that human rights analysis, with its emphasis on the universal and interconnected nature of economic, social, and political rights, offers a useful framework for hepatitis C treatment reform. Some of the needed reforms to improve access to hepatitis C treatment for people who inject drugs include, quite obviously, the rapid and immediate decriminalization of drug use and possession, as well as that of injecting equipment, and I would argue much wider drug law reform, leading ultimately to the regulation of all drugs of use. The removal of exclusionary or discriminatory treatment protocols as a matter of considerable urgency, and increased links between healthcare providers and community-led organizations of people who inject drugs, and the involvement of our organizations in treatment design and implementation, as well as measures to increase transparency in government and pharmaceutical company negotiations and the reduction of treatment price. New regimens of treatment and declarations of good intent, however, do not remove the long-standing imbalance between social control and care that has for so long deformed healthcare delivery for people who inject drugs and other criminalized communities. For many in the injecting community, public health arguments for hepatitis C treatment, particularly arguments for hepatitis C eradication and treatment as prevention, which has been a dominant theme in this conference with regards to HIV anyway, are likely and have frequently been viewed with some considerable suspicion by activists in the drug-using community, as we are aware that more often than not, we are treated as mere vectors of transmission and criminality, rather than as citizens entitled to health and social participation. Human rights arguments, which emphasize government responsibility to protect and fulfill the rights in economic, social, and political spheres, offer an alternative and powerful framework for conceptualizing the delivery of hepatitis C treatment and care for people who inject drugs, I would suggest. Hepatitis C amongst people who inject drugs is concentrated in high and middle income countries, with more than 2/3 of people living with HIV, living with hepatitis C, found in East and Southeast Asia, in Eastern Europe, in the US and Canada, and in Western Europe, according to a 2011 systematic review. Current and former people who inject drugs bear a disproportionate burden of chronic hepatitis C infection, accounting for an estimated 80 to 90% of new cases in high-income countries. And globally, an estimated 10 million injecting drug users are living with hepatitis C, with approximately 8 million chronically infected. And 3 countries in particular bear the heaviest burden. China, with 1.6 million injecting drug users living with hepatitis C. The USA, our neighbor to the south, with 1.5 million. And the Russian Federation, with 1.3 million. All of these countries, it should be noted, are excluded from the Gilead negotiated voluntary license. And so the 3 largest populations of people who inject drugs living with hepatitis C are currently excluded from treatment with new effective hepatitis C treatments. It should be noted too that co-infection with HIV is extremely common, more than extremely common, it's almost the norm. Indeed, 90% of HIV positive people who inject drugs are also living with hepatitis C, with disastrous effects for hepatitis C disease progression, which leads, amongst other things, to a 20-fold increase in the risk of cirrhosis. Clinical trials, in addition, generally exclude those who inject drugs, although a systematic review has recently found that treatment with the old standard of care, pegylated interferon and ribavirin, resulted in sustained viral response, SVR, of 55.9% amongst people who inject drugs, a rate that is only very slightly lower than that for other patients. There's also been found that treatment adherence amongst people who inject drugs was 82% across a number of different studies. And again, this is pretty much comparable to any other patient. And whilst risk of reinfection is frequently cited as a reason not to entreat active injectors for hepatitis C, it is sharing of contaminated injecting equipment rather than the act of injecting drug use itself that drives hepatitis C infection and indeed HIV infection. There is no inherent connection between injecting drug use and blood-borne virus acquisition. So we really must stop speaking of epidemics driven by injecting drug use. They are driven by criminalization and the lack of access to harm reduction interventions, clean needles and syringes. 2 minutes? Okay, I'll wrap up very quickly indeed. So I think we can draw some lessons from the HIV response. Although we are the vast majority of people living with hepatitis C, people in high-income countries, people who inject drugs in high-income countries report few experiences of hepatitis C treatment that are responsive to our needs. Previous experience of discrimination and confidentiality breaches in healthcare settings are commonly reported by people who inject drugs seeking hepatitis C treatment, and they're frequently given as reasons to avoid further treatment with new DAAs. And whilst treatment guidelines in high-income countries have been revised to replace the blanket exclusion of people who inject drugs with advice to consider patients on a case-by-case basis, we know that in reality this has come down to the exclusion of people who inject drugs from access to hepatitis C treatment. So we are still judged to be incapable of norms of stability or the recovery that are so often deemed to be the prerequisite for patient citizenship and new and effective hepatitis C treatment. Just to conclude, in order to achieve effective and acceptable levels of hepatitis C treatment for people who inject drugs, urgent drug law reform and decriminalization is needed, along with price reduction, and the removal and elimination of stigma, discrimination, and the blanket refusal to treat active injectors for hepatitis C. Thank you.